Hello, welcome to Chapter 13, Respiratory System Disorders. The respiratory system provides a way to transport oxygen from the air into the blood and remove carbon dioxide from the blood. Oxygen is necessary for cell metabolism, and the respiratory system is the only way to get that oxygen. Carbon dioxide is a waste material that results from cell metabolism. It influences the acid-base balance in the body fluids. The respiratory system consists of two anatomic areas: the upper respiratory tract, which is made of the passageways that conduct air between the atmosphere and the lungs, and the lower respiratory tract that consists of the trachea, the bronchial tree, and the lungs, where the gas exchange takes place. Pulmonary circulation, the muscles required for ventilation, and the nervous system all contribute to controlling that respiratory function. First, you inhale the air, and it enters the nasal passageway where it's warmed and moistened. Foreign materials then filtered out by the mucus in the hairs before that air enters the lung. The airflow continues through the nasal pharynx and the larynx into the trachea. On the posterior wall of the nasopharynx are located the pharyngeal tonsils, or the adenoids. These are made of lymphoid tissue, and they're another defense against inhaled foreign material. If the tonsils should become enlarged, they can obstruct the flow of air through the nasopharynx. The palatine tonsils, properly called the tonsils, are lymphoid tissue located in the posterior portion of the oral cavity. This slide showing you the anatomy of the respiratory system. The upper respiratory tract contains resident flora, whereas the lungs are sterile, containing no microorganisms. On the lower left corner of this slide, you can see the alveolar ducts and the alveolar sac, this little grape of cluster-like sacs where air exchange takes place. Sometimes those sacs will get fluid, bacteria, and other things in them, and that can interfere with the lung exchange. You'll see that in things like pneumonia. In emphysema, these sacs become destroyed or broken down, and the walls are damaged, so it's hard for that air exchange to take place. The pharynx, where the nasopharynx joins the oropharynx, serves as a common passageway for air and food, and it descends to the point of separation of the esophagus and the trachea. The epiglottis will protect the opening into the larynx or the voice box. It flips down during swallowing or ventilation. The larynx consists of cartilages and their associated muscles. The largest is the thyroid cartilage, which makes up the Adam's apple. There are two pairs of vocal cords, which are in the foldings of the mucous membrane: the upper or the false pair, and the lower pair, which constitutes the true vocal cords. The glottis is the true vocal cords and the space between them. When air is expired through the larynx, the true vocal cords will vibrate to produce the sound of the voice. The vocal cords, when approximated, help prevent food from entering the trachea and the lungs. As the inspired air is tracked downward through the larynx, it flows into the trachea or the windpipe. The wall of the trachea has 16 to 20 cartilage rings, fibroelastic tissue, and smooth muscle tissue. The trachea is flexible enough to allow bending and elongation. Those cartilage rings help prevent the trachea from collapsing and keep the airway open even with changes in the pressure. That inhaled air will continue into the right or left primary bronchus. The right bronchus is much larger and straighter, so it's the likely place that anything aspirated would end up. Each major or primary bronchus branches into smaller bronchi and then into bronchioles to form the bronchial tree. The cartilaginous rings are replaced by irregular plates of cartilage. The bronchi divide into bronchioles. The smooth muscle contracts or relaxes, adjusting the diameter of the bronchioles. Bronchodilation occurs when sympathetic stimulation relaxes the smooth muscle and dilates or enlarges the bronchioles. Elastic fibers are also present in the lung tissue to allow for expansion and recoil of the lungs during the breathing process. The respiratory mucosa is thin and it changes in the terminal and the respiratory bronchioles. In the bronchioles, air then flows into the alveolar ducts and the alveoli, or the air sacs. The alveoli are grape-like clusters. The alveoli are a single layer of epithelial tissue that promotes the diffusion of gas into the blood. This is the endpoint for inspired air where that gas exchange occurs. The respiratory membrane is combined alveolar and capillary wall. This thin membrane that allows the gas exchange to take place. The alveoli also have macrophages to help remove any foreign material that make it this far. Sometimes foreign material can still manage to make it beyond this point. The alveoli are coated with surfactant that's produced by special cells in the alveolar wall. This surfactant has a detergent action that reduces the surface tension of the alveolar fluid to promote inspiration and prevent collapse of the alveoli during expiration. When inspiration is complete, expiration reverses the airflow into the passageways to force the air out of the alveoli and back up the bronchi, trachea, and nose. Airflow depends on a pressure gradient. This is known as Boyle's law. This means that air always moves from high pressure to low pressure. Atmospheric pressure is higher than pressure in the alveoli. So inspiration is when air moves from the atmosphere into the lungs. Pressure in the alveoli is higher than in the atmosphere in expiration. So therefore, air moves from the lungs into the atmosphere. So how does this all work? Well, first of all, the lungs, okay, are going to change. So that diaphragm is going to drop down. It's going to elongate the lungs, okay? The phrenic nerve is stimulated, the intercostal nerves are stimulated, and this allows for expansion of the lungs, and that's going to decrease the pressure in them. So when that pressure is low, then that air from the atmosphere can move into the lungs during inspiration. Once you've inspired that air, it's been used, and it's ready to go back out, the diaphragm will move back up, the lungs will come back in, and the whole thing will decrease in size. This is going to increase pressure in that alveoli and make it higher than what it is in the atmosphere. And so that expiration process will take place now. The air will move from the lungs into the atmosphere. Pulmonary circulation itself, the muscles required for ventilation, and the nervous system all control this. Airflow during inspiration and expiration will depend on the pressure gradient, as I just explained. That air is always going to move from high pressure to low pressure. If the pressure in the atmosphere is higher than air pressure in the lungs, then air will move from the atmosphere into the lungs. We know this as inspiration. For expiration to occur, pressure must be higher in the lungs than it is in the atmosphere. Pressure changes in the lungs result from alterations in the size of the thoracic cavity. As the size of the thoracic cavity decreases, the pressure inside the cavity increases. This is Boyle's law. Now, if you look at this diagram, you can kind of see the changes that we're talking about here. The sequence of events that changes the size of the thoracic cavity and allows the process of inspiration and expiration. So first, inspiration starts with contraction of the diaphragm. This is considered the primary muscle of inspiration, and I would know that. Once that diaphragm is contracted and those external inner muscles are contracted, this will cause the diaphragm to flatten out and descend. This will increase the length of the thoracic cavity. The external intercostal muscles will raise up the ribs and the sternum and outward, increasing the transverse and the anterior posterior diameters of the thorax. The increased size of the thorax results in a decrease in the pressure inside the thoracic cavity and in the alveoli and the airways. So now that we have a decrease in pressure in there, it's less than what the pressure is in the atmosphere. As the ribs and the diaphragm move, the attached parietal pleura pulls the adhering viscera with it and the lungs along with it. As the visceral pleura moves outward, the elastic lungs expand. This causes that decrease in the air pressure in the lungs. At this point, the atmospheric pressure is greater than the pressure in those lungs, so air is able to flow from the atmosphere down into the alveoli. Understand that the thorax and the lungs have to expand before the air can enter the lungs. It's not the air entering the lungs that makes them expand. Breathing requires physical effort and cellular energy. So that means it requires ATP. In expiration, the diaphragm and the external intercostal muscles relax. This causes a decrease in the size of the chest cavity or the thoracic area. This decrease, combined with a natural elastic recoil of the alveoli, results in increased pressure in the lungs. So now the pressure in the lungs is greater than what it is in the atmosphere. So the air can flow out of the alveoli and back into the atmosphere. Expiration is considered a passive process, and it does not require any cellular energy or ATP. As far as pulmonary volumes, okay, you should understand what they are. The main ones I would expect them to ask you about are these three. So tidal volume, this is the amount of air that you breathe in and out with each breath. Your residual volume, this is the amount of air that remains in the lungs after you take that breath. Okay, and then the vital capacity, this is the maximum amount of air that can be moved in and out of the lungs with a single forced inspiration and expiration. Forced inspiration and expiration require additional energy and muscle activity. In forced inspiration, the sternocleidomastoid, the scalene, the pectoris minor, and the serratus muscles will contract to increase the elevation of the ribs and the sternum. During forceful expiration, the abdominal muscles contract to increase upward pressure on the diaphragm, and the intercostal muscles contract to pull the ribs and the sternum down and inward. Compliance is a term that we use to refer to the ability of the lungs to expand. It depends largely on elasticity of those tissues, but it can be affected by things like alveolar surface tension, and the size, shape, and flexibility of the thorax. Changes in ventilation can also occur during pregnancy. Pulmonary volumes measure the ventilatory capacity, which is the measure of the air moving in and out of the lungs with each normal or forced inspiration and expiration. Pulmonary volumes can change with disease, and they're helpful in monitoring a client's progress or response to treatment. For example, impaired expiration can cause an increase in residual volume and an increase in carbon dioxide levels in the body fluid. Tidal volume is the amount of air that moves in or out of the lungs with each respiratory cycle. Tidal volume is the actual amount of air exchanged with inspiration and expiration. Residual volume is the amount of air in the lungs after that forced expiration, and vital capacity is the amount of air expired following a maximum inspiration. The maximum amount of air a person can expel from the lungs after a maximum inhalation. And then you have total lung capacity. This is the total volume of air in the lungs after a maximal inspiration. Dead space is an area where gas exchange is not able to take place. Anatomic dead space includes areas such as the bronchi, the bronchioles. Dead space can be increased by obstruction in the passageways or by collapsing of the alveoli. Alveolar dead space is the volume of air that reaches the alveoli but never actually participates in the respiration process. This can reflect alveoli that are ventilated but not perfused. for example, secondary to a pulmonary embolus. Pulmonary volumes can help us. If we divide the total space within the lungs into volumes and capacities, it allows for assessment of the mechanical condition of the lungs, its musculature, airway resistance, and effectiveness of gas exchange. Pulmonary volume is the term that we use for various volumes of air moved by or associated with the lungs at any given point in the respiratory cycle. We measure volumes and capacities like simple spirometry. Simple spirometry can measure tidal volume, inspiratory reserve, expiratory reserve. However, it cannot measure residual volume. Measured values are standardized for height, age, and sex. Of these, height has the greatest influence on capacities. The primary control centers for breathing are located in the medulla and the pons. The inspiratory center in the medulla controls the rhythm, stimulating the phrenic nerves to the diaphragm and the intercostal nerves to the external intercostal muscles. These occur spontaneously in a rhythmic fashion, lasting about 2 seconds each. The expiratory center in the medulla acts primarily when expiration is required because normal expiration is a cessation of activity following each inspiration. Other centers in the pons also play a role in coordinating inspiration, expiration, and the intervals for each. The rate and depth of breathing set by the medullary center can be modified by a number of things. Any depression of the central nervous system activity, for example by drugs like morphine, can lead to slow, shallow breathing. The rate and depth of breathing can be modified by things like activity of the hypothalamus, the stretch receptors in the lungs, or the Herring-Brewer reflex, which prevents excessive lung expansion, or voluntary control, like some people use when they're singing, like Whitney Houston, for instance. This is how she holds those really long notes, is using some of these things that the body naturally has built into it. Of course, you have to practice this, and you also have to have a voice. Voluntary control is limited by the levels of carbon dioxide in the blood. When the concentration or the partial pressure of the carbon dioxide in the blood rises, breathing resumes automatically. For this reason, when a child intentionally holds his or her breath, they'll eventually have to breathe spontaneously. There are also chemoreceptors that sense changes in the levels of carbon dioxide, hydrogen ions, and oxygen in the blood or in the cerebrospinal fluid. The central chemoreceptors in the medulla respond quickly to slight elevations in PaCO2 or to a decrease in pH in the cerebrospinal fluid. The peripheral chemoreceptors, located in the carotid bodies of the bifurcation of the common carotid arteries in the aortic body in the aortic arch, are sensitive to decreased oxygen levels in the arterial blood as well as a low pH. The peripheral chemoreceptors will sense arterial levels and hydrogen ions. When peripheral chemoreceptors sense decreasing or acidic pH levels, they stimulate an increase in ventilation or increase the rate and depth to remove the carbon dioxide from the blood at a quicker rate. Removal of the carbon dioxide from the blood helps reduce the hydrogen ions and increase the body's pH level. Each cycle of respiration begins with inspiration and ends with expiration. In inspiration, the diaphragm and the external intercostal muscles contract. This enlarges the thoracic cavity. This causes a decrease in the pressure in those cavities, and so does the alveolar pressure. This forces the lungs to expand, allowing air to move in. Expiration occurs passively when the diaphragm relaxes. The respiratory center drives the respiratory cycle. The respiratory control center responds to altered levels of carbon dioxide and oxygen and changes the respiratory rate and pattern in response to it. A respiratory cycle is one sequence of inspiration and expiration. And there are two muscle groups used during normal inspiration, the diaphragm and the external intercostal muscles. When that diaphragm contracts, it moves inferiorly towards the abdominal cavity. This creates a larger thoracic cavity and more space for the lungs. Contraction of the external intercostal muscles moves the ribs upward and outward, causing the rib cage to expand, increasing the volume in the thoracic cavity. The expansion of the thoracic cavity forces the lungs to stretch and expand. That increase in volume causes a decrease in the pressure, especially in the alveoli, and that creates lower pressure than what is in the atmosphere. So that pressure gradient that's created here drives the air into the lungs. The process of normal expiration is passive, meaning that the energy is not required to push the air out of the lungs. Instead, the elasticity of the lung tissue causes the lung to recoil as the diaphragm and the intercostal muscles relax after inspiration. The thoracic cavity in the lungs will decrease in volume, causing an increase in pressure in the lungs. There are different types or modes of breathing that require a slightly different process to allow inspiration and expiration. Normal breathing is a mode of breathing that occurs at rest. It does not require you to think about it. During quiet breathing, the diaphragm and external intercostal muscles must contract. So this is just showing you the cycle of the respiratory control center. In the body, we have an increase in the carbon dioxide in the blood and the cerebral spinal fluid. This stimulates those central chemoreceptors in the medulla, stimulates the inspiratory muscles, increases the respiratory rate. This removes more carbon dioxide from the body. That decreases the carbon dioxide levels. We have a decrease to the stimulation of those chemoreceptors. That slows the respirations. The body starts to retain more carbon dioxide, and then the whole process repeats itself. Hypercapnia is when we have too much carbon dioxide in the body, and too much carbon dioxide can cause respiratory acidosis, which will depress the central nervous system. Hypocapnia is when we don't have enough carbon dioxide in the body. This can be caused by things like hyperventilation, and hypocapnia can lead to respiratory alkalosis. Hypoxemia is when we don't have enough oxygen in the blood. A marked decrease in the oxygen from 105 to 60 is necessary before chemoreceptors will respond to the actual hypoxemia. Carbon dioxide can easily diffuse into the cerebral spinal fluid. Blood levels of oxygen also influence the respiratory rate. The peripheral chemoreceptors are responsible for sensing large changes in oxygen levels. Normal oxygen levels provide a substantial reserve of oxygen in the blood. Therefore, a large decrease in the oxygen is necessary before the chemoreceptors would respond to hypoxemia. The control mechanism is important for clients with chronic lung disease because their body adapts to a sustained level that's elevated of carbon dioxide, and this moves towards a hypoxic drive. These clients are dependent on low oxygen levels rather than the slight elevation of carbon dioxide in order to stimulate breathing. Therefore, it's important for these patients to remain slightly hypoxic and not be given excessive amounts of oxygen at any time. Hypoxia is inadequate oxygen to the cells. The hypoxic drive is a form of respiratory drive where the body uses chemoreceptors or oxygen instead of carbon dioxide receptors to regulate the respiratory cycle. Normal respiration is driven mostly by levels of carbon dioxide in the arteries detected by peripheral chemoreceptors and very little by oxygen. In patients with chronic lung disease, the pons region of the brain becomes sensitized to the constant increases of the elevated carbon dioxide. Regulation for them is based on the oxygen level in the blood. The increased oxygen will tell the brain to stop breathing. So this is why we have to control how much oxygen that we give them. So if you look on the top here on this slide, the hypoxic drive with the chronic elevated levels. So somebody that has emphysema or COPD, they have a chronic elevation of carbon dioxide. The medullary chemoreceptors that are supposed to respond to that will eventually become insensitive to this. The carbon dioxide levels will increase. The oxygen levels will slightly decrease. There's no increase in respiration here. We have marked decrease in the oxygen levels. The very low oxygen will stimulate the peripheral chemoreceptors, and that will stimulate the inspiration for these clients. The increase in the respirations will remove the carbon dioxide and help them take in more oxygen. But then that increase in the oxygen will slow the respirations, and then the PO2 the PCO2 will start to increase again, and PO2 will start to decrease. Hypocapnia is low carbon dioxide levels in the body. It can be caused by hyperventilation or by excessive amounts of carbon dioxide leaving the body, and it can lead to respiratory alkalosis. Gas exchange is the flow of gas between the alveolar air and the blood in the pulmonary circulation. Gas exchange in the lungs depends on the concentration or the partial pressure of the gas, as we talked about earlier. Movement of gas always goes from high pressure to low pressure. So it's customary to refer to the concentration of a gas in a mixture as the partial pressure of that gas. For example, the partial pressure of oxygen is listed as PO2. When the measurement refers specifically to the partial pressure of oxygen in arterial blood, it's expressed as PaO2. Carbon dioxide diffuses out of the pulmonary capillaries into the alveoli depending on its concentration. Each gas in the mixture moves or diffuses according to its own partial pressure gradient and dependent of other gases. This is known as Dalton's law. Again, each gas in a mixture moves or diffuses according to its own partial pressure gradient and independent of other gases, known as Dalton's law. For example, oxygen diffuses from alveoli, an area with high concentration of oxygen, to the blood in the pulmonary capillary, which has a lower concentration of oxygen, until concentrations become equal. The atmosphere contains oxygen, carbon dioxide, nitrogen, and water. Because all the air is not totally expired from the alveoli during expiration, and it's humidified during its passage into the lungs, alveolar air has different concentrations of gases than either the atmosphere or blood. The residual air in the alveoli allows continuing gas exchange between expiration and inspiration because blood is continually flowing through that pulmonary circulation. Pulmonary circulation is composed of pulmonary arteries, which bring that deoxygenated blood from the right ventricle of the heart to be oxygenated. It's the only artery that carries deoxygenated blood. The pulmonary capillaries is where the diffusion or the gas exchange occurs, and then those pulmonary veins bring that oxygenated blood back to the left atrium of the heart. This is the only vein that carries oxygenated blood. Oxygenated blood then moves from the left ventricle of the heart, which pumps the blood into the aorta and into systemic circulation. Alveoli are located at the distal ends of the bronchial tree. This is where the gas exchange of the oxygen and the carbon dioxide take place. Every alveoli is surrounded by a nest of blood capillaries supplied by small branches of the pulmonary artery. There's about 280 billion capillaries. That's a lot. This results in a vast surface area for the gas exchange. The oxygen is diffused across the membrane into the capillaries, and the carbon dioxide is released from the capillaries into the alveoli to be breathed out. The alveoli consist of epithelial layers of simple squamous epithelium. This is very thin, flat cells. The epithelial lining is part of the alveolar membrane that allows the gas exchange. The membrane has several layers, a layer of alveoli lining, fluid that contains surfactant, the epithelial layer, the thin interstitial space between the epithelial lining and the capillary membrane, a capillary basement membrane that fuses with the alveolar membrane, and the capillary endothelial membrane. Elastic fibers allow the alveoli to stretch when they fill during inhalation with air. Then they are able to spring back during exhalation in order to expel the carbon dioxide. Partial pressure is extremely important in predicting movement of the gases. Remember, the gases tend to equalize their pressure in two regions that are connected. The gas will move from the area where its partial pressure is higher to the area where the partial pressure is lower. In addition, the greater the partial pressure difference between the areas, the quicker the gas will move. For gas exchange to be efficient, the volumes involved in ventilation and perfusion have to be compatible. Factors like gravity effects on blood, blocked alveolar ducts, which you might see in someone with cystic fibrosis or disease, can cause ventilation and perfusion to be imbalanced. When ventilation is sufficient, oxygen enters the alveoli at a high rate, and the partial pressure of oxygen in the alveoli remains high. In contrast, when ventilation is insufficient, partial pressure of oxygen in the alveoli will drop. Without the large difference in the partial pressure between the alveoli and the blood, the oxygen is not diffused efficiently. When ventilation is not sufficient for the alveoli, the body redirects the blood flow to the alveoli that are receiving enough ventilation. So it's going to bypass that area and try to go to an area where the perfusion can happen better. This is achieved by constricting pulmonary arteries, which redirects the blood to other alveoli that have sufficient ventilation. Factors like carbon dioxide, oxygen, and pH levels all serve as stimuli to adjust the blood flow in the capillary networks associated with the alveoli. Ventilation is regulated by the diameter of the airways, whereas perfusion is regulated by diameter of the blood vessels. Let me say that again. Ventilation is regulated by diameter of the airways, whereas perfusion is regulated by the diameter of the blood vessels. The diameter of the bronchioles is sensitive to the partial pressure of carbon dioxide in the alveoli. A greater partial pressure of carbon dioxide in the alveoli causes the bronchioles to increase their diameter, as will a decreased level of oxygen in the blood supply, allowing the carbon dioxide to be exhaled from the body at a greater rate. So again, here the body is adjusting, okay, with that greater pressure of carbon dioxide in the alveoli. Those bronchioles are going to increase in size. A decrease in the level of oxygen will also cause those bronchioles to increase in size. And this allows more carbon dioxide to be exhaled from the body at a quicker rate. In addition to the partial pressure gradient, diffusion can be altered by other factors such as the thickness of the respiratory membrane. When fluid accumulates in the alveoli or interstitial tissue, diffusion, particularly of oxygen, is greatly impaired. And I said that this can happen in things like pneumonia or congestive heart failure. Pressure in the pulmonary circulation is normally low, reducing the risk of excessive fluid in the interstitial space and the alveoli. Extra fluid in the interstitial space and alveoli impedes blood flow through the pulmonary capillaries and increases surface tension in the alveoli, restricting expansion of the lungs. Major factors that affect gas exchange are the total surface area available for diffusion and thickness of the alveolar membranes. The alveoli are totally responsible to provide an adequate surface area for ventilation and perfusion, and they have to be working correctly for diffusion to occur. If part of the alveolar wall is destroyed, like in emphysema or in fibrosis, which occurs in the lungs, the surface area is greatly reduced. If the airflow into the alveoli is obstructed or the capillaries are damaged, the surface area becomes non-functional. This imbalance is measured by VQ ratio, or the ventilation perfusion ratio. The ventilation rate is the volume of gas inhaled and exhaled in the lungs in a given period of time, usually over 1 minute. The perfusion of the lungs refers to the total volume of blood reaching the pulmonary capillaries in a certain time period. An autoregulatory mechanism in the lungs can adjust ventilation and blood flow, trying to produce a good match. For example, if the PO2 level is low because of poor ventilation in an area, vasoconstriction occurs in the pulmonary arterioles to shunt the blood to other areas of the lungs where ventilation may be better. If airflow is good, the pulmonary arterioles will dilate to maximize that gas exchange. A VQ mismatch is an imbalance between the ventilation and the perfusion in the lungs, and it means that certain regions or areas of the lungs are not optimally exchanging gas because of inadequate ventilation due to either poor blood flow, inadequate blood flow relative to the ventilation. Imbalances in this ratio can lead to critical respiratory conditions. Ventilation perfusion ratio mismatch is a condition that happens when the ratio is not properly matched, and so we see ventilation perfusion mismatch or dead space ventilation. VQ mismatch can be caused by various factors, such as lung conditions like a pulmonary embolism, asthma, COPD, and lung diseases that affect the interstitial area. Only about 1% of oxygen is dissolved in plasma. Oxygen is relatively insoluble in water, limiting the ease through which oxygen can diffuse. The dissolved form of the gas diffuses from the alveolar air into the blood in the pulmonary capillaries and also diffuses into the interstitial fluid and the cells during the process of internal respiration. Most oxygen is transported reversibly bound to hemoglobin by iron and called oxyhemoglobin. When all four heme models in the hemoglobin have taken up oxygen, the hemoglobin is termed fully saturated and measured or expressed as SaO2. As the oxygen diffuses from the blood into the interstitial fluid and cells, hemoglobin releases the oxygen to replace it. In someone with sickle cell, their hemoglobin is SS hemoglobin instead of hemoglobin A, which is normal hemoglobin. So when the hemoglobin releases the oxygen, it causes the cell to sickle. Hemoglobin controls the shape of the cell, so that's part of the issue because it's not regular hemoglobin. All right, and also when the oxygen is released, it destroys the red blood cell. So these cells are only going to live about 10 to 20 days. Dissolved oxygen is always available in the plasma, ready to diffuse in the cell. The rate at which the hemoglobin binds or releases oxygen depends on factors such as the partial pressure of oxygen or the PaCO2, the temperature, and the pH. Carbon dioxide is considered a waste product from cell metabolism. It's dissolved in the plasma and can diffuse easily across the membranes. Some of it is dissolved in the plasma, and some additional, about 20%, is reversibly bound to the hemoglobin and attached to an amino group on the globin portion, not the heme. This is termed carbamino hemoglobin. The majority of carbon dioxide resulting from cell metabolism diffuses into the red blood cells. This is the oxyhemoglobin dissociation curve, and it's a graph that shows the relationship between the amount of oxygen bound to the hemoglobin and the partial pressure of oxygen. It actually plots the proportion of saturated hemoglobin on the vertical axis and the oxygen tension on the horizontal axis. This is a tool to try to help understand how the blood carries and releases the oxygen. The curve is considered sigmoidal with a steeper slope at the lower oxygen levels and a more gradual slope at the higher levels. Factors like pH, temperature, PCO2, carbon monoxide, and hemoglobin can affect the curve, shifting it left or right. This shows how likely hemoglobin is to release the oxygen into the tissues. Common tests that we might use are spirometry. Pulmonary function testing is used to test pulmonary volumes, measure volume and airflow times. ABGs, which look at the oxygen, carbon dioxide, bicarb levels, as well as the pH. Oximeters, which measure the oxygen saturation. And then exercise tolerance testing is useful in patients that have chronic pulmonary disease to diagnose and monitor the patient's progress. Radiography or chest x-rays can be helpful to evaluate tumors or infections such as pneumonia or TB. Bronchoscopy can be used to perform a biopsy or check for the site of a lesion or bleeding. We also might have to use a bronchoscopy if someone has like mucus plugs to help remove them sometimes. Culture and sensitivity tests on the exudate from the upper respiratory tract or the sputum to help identify pathogens or assist with determining the correct treatment. Sneezing is considered a reflex that's caused by irritation to the upper respiratory tract. It helps remove any irritants. It's also associated with things like inflammation or foreign material in the nasal passages. Coughing is from irritation caused by a nasal discharge dripping into the oropharynx, or from inflammation or foreign material in the lower respiratory tract, or from inhaled irritants such as tobacco smoke. A persistent cough could be evidence of a respiratory chronic irritation. However, it could be in response to things, sometimes even like a medication, like an ACE inhibitor. They cause a chronic irritating cough, and sometimes we have to switch them over to ARBs. Aspiration of food or fluid can cause a spasm or coughing spell. If the cough reflex is controlled by the medulla and consists of coordinated actions that inspire air and then close the glottis and the vocal cords. A constant dry or unproductive cough can be fatiguing, and it interferes with things like sleep, and the respiratory muscles are used excessively. Sputum from the respiratory tract has significant characteristics depending on its abnormality. Normal secretions are relatively thin, clear, and colorless or cream color. Yellow, green, cloudy, thick mucus is usually a sign of some sort of bacterial infection. Rusty or dark colored sputum is often seen in pneumococcal pneumonia. Large amounts of purulent pus-containing sputum with a foul odor may be associated with bronchiectasis. I would know that. And then thick, tenacious, sticky mucus can occur in clients that have asthma or cystic fibrosis because that really plugs up all the ducts in the body, but especially the lungs, the pancreas. Blood-tinged secretions can result from a chronic cough or irritation that causes rupture of the superficial capillaries, but it could also be a sign of a tumor or TB. Next is hemoptysis. You should know the difference between hemoptysis and hematoemesis. Hematoemesis, we usually have vomiting of blood, and it's usually going to be dark in color, like a coffee ground sort of look. With hemoptysis, I'll say hemoptysis, you coughed it up, gotta mop it up. That's how I remember it. Hemoptysis, you coughed it up, gotta mop it up. So this is like a blood-tinged frothy sputum. We usually see it in people with pulmonary edema. You can also see it in people with TB. Then we're looking at breathing patterns and characteristics. So eupnea, this is considered normal and usually 10 to 18 breaths per minute. We look at the pattern and the rate. Changes in the rate, the depth, and the effort can tell us important information about the client. Kussmaul's respirations, these are deep, rapid respirations or air hunger, and this can typically happen in someone with either a metabolic acidosis or after strenuous exercise. Any type of labored respiration or prolonged inspiration or expiration is usually associated with some sort of obstruction of the airway. Wheezing or whistling sounds usually indicate obstruction in the small airways. We might hear that in someone with like asthma. And then stridor, this is high-pitched crowing noise, and this usually indicates a medical emergency. This is usually some sort of upper airway obstruction. This chart is showing you the different respiratory patterns. I'd be familiar with eupnea, which is your normal, tachypnea, which is fast, bradypnea, which is slower than normal, apnea, that's cessation of breathing. So we might see this in someone that has sleep apnea. We might also see this in babies. It just can't be longer than a certain length of time. Hyperapnea is going to be increased. Cheney-Stokes, we usually call that the death rattle. Here you have periods of apnea, and usually you hear a little bit of noise in there. And then Kussmaul's, which we talked about, are deep, regular respirations with an increase in the rate. So those are the main ones that I would be familiar with. We also like to listen to those long sounds. They can be abnormal or absent in certain respiratory disorders. So rels and rhonchi are abnormal sounds from air mixing with excessive secretions in the lungs. Rels are typically a light, bubbly, or crackly sound, and usually with these, you can have someone cough and they'll go away. If they have something like congestive heart failure or pneumonia, they're not going to go away. Rhonchi is usually a deeper, harsher sound from thicker mucus. And then also absence of breath sounds indicates non-aeration or collapse of the lungs. So never a good thing when we don't hear that air moving. Dyspnea is a subjective feeling of discomfort that occurs when the person is unable to inhale enough air. It could be caused by increased carbon dioxide or hypoxemia. The person may manifest it or describe it as breathlessness or shortness of breath with exertion or at rest. So exertion would be like when they're going upstairs. Severe dyspnea can be accompanied by flaring of the nostrils, use of the accessory respiratory muscles, or retraction of the muscles. For example, the retractions that you see between the ribs in that intercostal area or around that sternocleidomastoid area. Orthopnea is dyspnea that someone experiences when they're lying down. It can be caused by pulmonary congestion, and it develops as the blood pools in the lungs when that person lies down, and the abdominal contents start to push up against the lungs, raising the upper part of the body with pillows. Sometimes helps here, or sometimes they have to end up sleeping like in a recliner or something along that line. Paroxysmal nocturnal dyspnea is a sudden acute type of dyspnea that can happen in patients with left-sided heart failure. During the sleep, the body fluid is redistributed. This causes pulmonary edema, and the person wakes up gasping for air and coughing. So again, that blood is all pooling into that chest area. Cyanosis is blue coloring of the skin and mucous membranes from large amounts of unoxygenated hemoglobin in the blood. It can develop in the peripheral areas due to exertion, or it can be more generalized. This can happen in clients with cardiovascular and respiratory issues, and it has to be considered in conjunction with other data. It's not a reliable source or indicator for hypoxia. Pleuropain can happen from inflammation or infection of the parietal pleura. It's a cyclic type of pain that increases as the membrane becomes stretched or um, larger with that inspiration or with coughing. And also sometimes they'll have a friction rub. A friction rub is a soft sound produced as the membranes start to rub against each other. Pleural inflammation can be caused by lobar, pneumonia, or by lung infarction. They can also develop club fingers. This usually happens over a long period of time, and sometimes they'll have club toes as well. This is usually a result of chronic hypoxia with respiratory or cardiovascular disease. It's these painless, firm, fibrotic enlargements at the end of the digit. So basically, the fingers look rounded on the tips. Changes in the ABGs, hypoxemia, refer to inadequate oxygen in the blood. Hypoxia is inadequate oxygen to the cells. Okay, so hypoxemia is in the blood. Hypoxia is to the cells. Hypoxia or hypoxemia can have different causes. Deficits of red blood cells or hemoglobin levels that are too low to adequately transport oxygen. Circulatory impairment can cause decreases in cardiac output. There can be an excessive release of oxygen from the red blood cells if the circulation is sluggish or obstructed by some sort of vascular disease or a problem. Impaired respiratory function, including inadequate ventilation or inhalation of oxygen deficient air or impaired diffusion. Carbon monoxide poisoning, because the carbon monoxide can bind tightly to the heme and displace the oxygen. With the carbon monoxide, you won't see obvious signs of hypoxia, but what you'll see is bright red coloring of the skin and the mucosa, and typically they'll have a headache or be drowsy. It can also affect ventilation, but it can kill you quickly and quietly. Remember, I talked about this in class that both my grandmother and my brother-in-law died from carbon monoxide poisoning. People will often use this as a means of suicide. Hypoxia affects cell metabolism, reduces the cell's function, leads to anaerobic metabolism, which is then going to cause them to start to produce lactic acid, and that can cause the development of metabolic acidosis. The brain is susceptible to oxygen deficits more than any part of the body because it doesn't really have that storage capacity that we see in other areas of the body, but yet it constantly needs the oxygen. Cerebral hypoxia stimulates the sympathetic nervous system. Decreased cell function would be indicated by fatigue, lethargy, stupor, and muscle weakness. Extreme or prolonged hypoxia can cause death to the cell. Compensation mechanisms for hypoxia result from respiratory impairment and include increased cardiovascular activity such as tachycardia and increased blood pressure. In people that have chronic hypoxia because of respiratory or circulation impairment, erythropoietin secretion is increased, stimulating the bone marrow to produce additional red blood cells, and that causes them to develop something called secondary polycythemia, where they have too many red blood cells, and now the blood is very viscous. Acid-base imbalances can also develop from respiratory disorders, respiratory acidosis because of excess carbon dioxide in the blood. This is more common and results from impaired expiration. Hypercapnia, central nervous system depression, ABGs in this situation indicate high carbon dioxide levels and a low pH. Respiratory alkalosis occurs when the respiratory rate is increased, usually because of acute anxiety or excessive intake of aspirin. This chart shows different therapies for respiratory disorders. Remember, for patho, you are not responsible for these. You may want to know them later, but right now for this course, you just need to know how it breaks the body and what does it look like when it breaks the body. All right, next up is infectious diseases. We'll be talking about lower and upper respiratory tract infections. We'll start with the upper. So some of the upper respiratory tract infections we'll see are the common cold, sinusitis, epiglottitis, which is a medical emergency, influenza, and scarlet fever, which you'll want to know about as well. The common cold is caused by viral infection of the upper respiratory tract. So a virus is what causes this. The most common is rhinovirus, but it could also be adenovirus, parainfluenza virus, or coronavirus. It's spread through respiratory droplets, either directly inhaled or on the hands in secretions on contaminated objects like facial tissues. It's brief, self-limited, but highly contagious because the virus is shed in large numbers from the infected nasal mucosa during the first few days of the infection, and they can survive out of the body for several hours. Signs and symptoms of a cold are swollen, red nose and pharynx, increased secretions, nasal congestions, copious water discharge, postnasal drip, sneezing, coughing, watery eyes. Breathing from the mouth is common, and sometimes we'll hear a change in the tone of the voice. They may also develop a sore throat, headache, fever, malaise, or cough. Infection and inflammation can be spread to cause pharyngitis, laryngitis, or acute bronchitis. And we're going to skip this slide because again, we don't need these slides, okay? For a treatment, you're not required to know treatment for patho. So this slide shows how the virus attaches to the respiratory mucosa, which is continuous, and that allows it to invade the tissue, cause necrosis, inflammation, and swelling, which leads to that congestion in the obstructed airways. The virus will spread along that continuous mucosa, and it can invade things like the ears, causing otitis media, the sinuses, causing sinusitis, the bronchi, the lungs, causing pneumonia. Bacteria, sometimes resident flora, are able to penetrate that damaged mucous membrane and cause a secondary bacterial infection. Sinusitis is a bacterial infection secondary to a cold or allergy. It obstructs the drainage of one or more of the paranasal sinuses into the nasal cavity. Most cases are caused by nasal polyps, a deviated septum, or respiratory infection. Common organisms include pneumococci, streptococci, Haemophilus influenza, or other various respiratory viruses and fungi. As the exudate builds up, pressure also builds up in the sinus cavity. This causes severe pain in the facial bones. The pain can be confused with a headache or a toothache, especially if the ethmoid or maxillary sinuses are affected. Symptoms include pain in the facial bones, nasal congestion, fever, and sore throat. Diagnosis can be confirmed using radiography or transillumination. Laryngotracheobronchitis, also known as croup, is a common viral infection in kids between the ages of 1 and 2. Adults can also contract laryngitis, tracheitis, or bronchitis. Common organisms are parainfluenza viruses and adenoviruses. The infection starts as an upper respiratory condition with nasal congestion and cough. In the young child, the larynx and the subglottic areas become inflamed with swelling and exudate. This causes obstruction and the characteristic bark cough or seal-like cough, which give it the name croup, horse cough, or inspiratory stridor. It's typically more severe at night and will turn on the shower, crack the window, try to provide cool, moisturized air, either from a humidifier, shower, croup tent, to try to relieve the obstruction. And that usually does it. Okay, some of these kids end up at the ER, but usually this is self-limited and they'll fully recover within a few days. Sometimes the smooth muscle can start to spasm, and that can exacerbate the obstruction and require additional care here. But most of the time, this is relieved just by the cool, moist air. I would look at this chart. This chart tells you the difference between the laryngotracheobronchitis or the croup, the epiglottis, and the bronchiolitis, which is the RSV. Okay, with epiglottitis, what are we going to see? So this usually happens in kids 3 to 7, caused by Haemophilus influenza. The supraglottic area becomes inflamed. The epiglottis becomes obstructed. All right. And so we're going to talk about that a little bit more. But these kids are going to be in a tripod position. They'll be drooling, high fever, anxious, and then RSV spread by droplets. Usually see this in kids 2 to 12 months. Now we see them advertising this a lot for adults. Adult RSV, them getting vaccinated. Here we have inflammation of the mucosa and the bronchioles obstructing the small passages. So we see shortness of breath, paroxysmal cough, wheezing, chest retractions, and nasal flaring. Let's look at them a little bit more. So epiglottitis is considered an acute infection. Again, it's common in kids age 3 to 7. It is a medical emergency. This infection, usually caused by the Haemophilus influenza type B, is common in kids 3 to 7. It causes swelling of the larynx, the supraglottic area, and the epiglottis. So this area is going to look like a round red ball when you look inside the airway. Okay, onset is rapid. Will have a fever, sore throat. The child will refuse to swallow, so they'll present with drooling. Inspiratory stridor is going to be heard here. The child will look anxious and pale and assume a tripoding position because they can't breathe. All right, and they're really struggling to breathe here. You're also not going to put anything in that mouth because that can trigger what we call a laryngospasm and actually kill the child. So we have swelling of the larynx, the supraglottic area, and the epiglottis. It can obstruct the airway. Spasm of the larynx is common if we touch anywhere in there with instruments. And the treatment for this is oxygen. Influenza, a viral infection that can affect the upper and lower respiratory tract. There's 3 groups, type A, B, and C. The viruses mutate constantly, preventing effective immune defenses for prolonged periods of time. The flu has a sudden acute onset with fever, marked fatigue, aching pains in the body. It can also lead to viral pneumonia. A mild case of the flu could be complicated by secondary problems such as bacterial pneumonia. Most deaths during the flu epidemic result from some type of pneumonia. Again, this is treatment. Take a peek at it, but you don't need to know it for these exams. All right, next up is scarlet fever. I would know this one. This is an upper respiratory infection caused by group A beta hemolytic streptococcus. Incubation period 1 to 2 days. Symptoms here are fever with the sore throat, chills, vomiting, abdominal pain, and malaise. Typical manifestation is that strawberry tongue, and that strawberry tongue is caused by the exotoxin that's produced by the bacteria. They'll also have a fine rash on the chest, neck, groin, and thighs. Once this was a serious childhood disease, now it's usually treatable with some sort of antibiotics. So this is a picture of that strawberry tongue from the scarlet fever. And again, the typical strawberry tongue is produced by the exotoxin in the bacteria. All right, now we're going to talk about lower respiratory tract infections, bronchiolitis, pneumonia, SARS, COVID-19, tuberculosis, histoplasmosis, and anthrax. Next is bronchiolitis. This is a common infection in young children caused by RSV, myxovirus. It's transmitted directly by oral droplets, occurs more frequently in the winter. Predisposing factors are asthma and cigarette smoking. Bronchiolitis varies in severity. The virus itself causes necrosis and inflammation in the small bronchi and bronchioles with edema. We'll see increased secretions, reflex bronchospasms, which eventually cause obstruction of the small airways. Symptoms include wheezing, shortness of breath, rapid, shallow respirations, cough, rales, chest retractions, fever, and malaise. There may be areas of hyperinflation with air trapping because of the partial obstruction, or areas of atelectasis or non-aeration resulting from total obstruction. Next up is pneumonia. Classification of pneumonia is often based on the causative agent. It can be viral, bacterial, or fungal. The pneumonia could be in both lungs or consolidated in one lobe, and it can cause changes in the interstitial tissue, the alveolar septae, the alveoli. Also, it could be nosocomial or community acquired. Pneumonia can develop as a primary acute infection or a secondary one due to some other respiratory condition where the tissue resistance is reduced. It's a risk following any aspiration or inflammation in the lungs, whenever fluids pool in the lungs, or if the defense mechanisms like the cilia are not working properly. In most cases, the organism will enter the lung directly by inhalation, like a virus, or the resident bacteria can spread along the mucosa. It can also be aspirated in secretions, and sometimes the infection is blood-borne. In immunosuppressed individuals, other organisms such as Candida, fungus, or Pneumocystis carinii can cause pneumonia, and sometimes that pneumonia will lead to their death. You'll see that in like some of your AIDS patients. And in some pneumonias, such as viral pneumonia, the pathophysiology will change primarily in the interstitial tissue or the alveoli septae. In other types, such as pneumococcal pneumonias, the alveoli are inflamed and filled with exudate. This results in a solid mass in the lobe. So sometimes with the lungs, when you're listening, you'll hear like a dull sound, and it's that solid mass, and we know that it's likely a pneumonia or some issue there. Nosocomial pneumonia usually happens in the hospital to people that have less resistance, the elderly, someone malnourished, or immunosuppressed. And a lot of times we'll see these with gram-negative organisms like the Klebsiella pneumoniae or Pseudomonas. Community-acquired pneumonia can be viral or bacteria. It can affect healthy people even. For example, after someone has the flu, they might develop this, or if they have some sort of underlying cardiovascular or respiratory problems. Aspiration pneumonia can be nosocomial or community acquired, but it usually involves aspiration of vomitus, irritating the tissues, or nasal secretions. When periodontal disease is present, aspiration pneumonia can result from infection by gram-negative microbes as well. So bad teeth can also lead to this if you have bad teeth and it's draining in your mouth. We're going to go over each one of these types of pneumonia, but the ones that you really should focus in on are the lobar pneumonia. I would look at these charts and the atypical pneumonia. Those are the ones they typically like to ask questions about. This slide here is just trying to show you the different changes that can occur with the different types of pneumonia in the lung. So like with number 3 there, you can see that's the mycoplasmal or the atypical pneumonia. Number 2 is the lobar pneumonia, and then number 1 is the bronchopneumonia, and where it's affecting and how. So again, this can affect perfusion in the lungs for a variety of reasons, but most of the time because those alveoli are going to be affected as well. We'll talk about this with each of the pneumonias on the slides to follow. So lobular pneumonia, this is more of a bacterial pneumonia. It's infection, and it's going to be localized in one or more of the lobes. Sometimes it will colonize in the nasal pharynx without producing any symptoms. First stage in development is congestion. So we have inflammation and vascular congestion in the alveolar wall, and the exudate forms in the alveoli, and that's going to interfere with oxygen diffusion. Next, the neutrophils, the red blood cells, and fibrin will accumulate in the alveolar exudate and cause it to form a solid mass in the lobe known as consolidation. The red blood cells in the exudate produce the rusty colored sputum associated with this type of pneumonia, especially the red. Eventually, the red blood cells break down, and as the infection resolves, macrophages break down the exudate and allow it to be expectorated or reabsorbed. Because a complete lobe is usually involved in the inflammatory process, the pleurae adjacent to it are often involved, and this causes pleuritic pain in the affected site, pleurisy or pleuritis. Infection can spread to the pleural cavity, causing empyema. If not resolved quickly, the empyema can cause adhesions between the pleural membranes and restrict ventilation. Chest x-rays help confirm the infection, and a sputum culture will help identify the organism. The purpose of this slide is to show you what the organisms would look like on a slide. As the alveoli fill, it reduces the diffusion of the gases, especially the oxygen. It decreases blood flow through the affected lobe. This leads to hypoxia. There's also an increase in the demand for oxygen because of the higher metabolic rate associated with the infection. The oxygen deficit leads to metabolic acidosis. Dehydration can happen because of the high fever, the hyperventilation, and the inadequate fluid intake. Typical manifestations of pneumococcal pneumonia include sudden onset, systemic signs of high fever with chills, marked fatigue, and leukocytosis, dyspnea, tachypnea, tachycardia, pleuritic pain with splinting, meaning they're grabbing their sides sometimes, or their chest because of the pain. Rails over the affected lobe, and then it will eventually be a dull sound as the consolidation occurs. Productive cough with rusty colored sputum, confusion and disorientation if the infection is severe or multiple lobes are affected. So this slide is just showing you what the lung looks like when it's affected by the pneumonia. Next one is bronchopneumonia. Bronchopneumonia happens as a diffuse pattern of infection in both lungs, more often in the lower lobes. There are different species that can cause the infection. It usually starts in the bronchial mucosa and spreads to the alveoli. In a lot of cases, the pooled secretions in the lungs will become infected by organisms draining from the other upper passageways. A particular hazard in a client that is bedbound, they can develop something called hypostatic pneumonia. The inflammatory exudate forms in the alveoli, which interferes with the diffusion of the oxygen. The onset tends to be slow with a moderate fever, cough, and rales. Congestion can lead to a productive cough with purulent sputum, usually yellow or green in color. The sputum culture and sensitivity tests will tell us the right choice for treatment based on the pathogen. This slide is showing you the bronchial pneumonia and how it affects the lungs. Next is Legionnaire's disease. This is caused by Legionella pneumophilia. It likes to live in warm, moist environments. It's often considered nosocomial. It is going to be in places that have poor air conditioning systems, leaky pipes, spas. It can happen in hospitals, institutions, or other places that fit this criteria, especially among those that have any sort of other lung disease. It's hard to identify. It requires a special type of culture. And if it's not treated, it can lead to severe congestion, consolidation, necrosis in the lungs, and it can be fatal. Primary atypical pneumonia. This is different from other types of pneumonias in both the causative agent and whether it's viral or mycoplasmal. The pathology is going to involve the interstitial inflammation here. Mycoplasma pneumoniae is typically found in the upper respiratory tract. It's common in older children and young adults. It's transmitted by aerosol, but not considered highly contagious. Frequent cough is a prominent sign. Mycoplasma responds to erythromycin or tetracycline usually. The viral pneumonia is caused by influenza A or B, sometimes by adenovirus or RSV. The infection begins slowly with inflammation in the mucosa of the upper respiratory tract and then descends to involve the lungs. The organisms produce inflammation that's diffuse and interstitial, so there's little exudate forming in the alveoli. The cough is going to be unproductive and rels are not pronounced. Typically, we'll see poorly defined patches of congestion. The onset of primary atypical pneumonia is often vague with a non-productive cough, hoarseness, sore throat, headache, mild fever, and malaise. The infection is usually self-limiting. Then chlamydia pneumonia, which is caused by the organism chlamydia, and it's also considered to be a type of PAP and pharyngitis. Infection is mild, so sometimes it's not diagnosed. Pneumocystis carinii pneumonia. This is a type of atypical pneumonia that occurs as an opportunistic infection, often fatal in clients with AIDS. It can cause pneumonia in premature infants as well. This microbe was formerly classified as a protozoan, but now it's considered a fungus. It appears to be inhaled. It attaches to the alveolar cells, causing necrosis, diffuse interstitial inflammation. Then the alveoli fill with exudate and fungi, including the cystic form. The onset is marked by difficulty breathing and a non-productive cough. SARS, this is an acute respiratory infection. The causative microbe is coronavirus. It's an RNA virus transmitted by respiratory droplets during close contact. Incubation period is approximately 2 to 7 days. The first stage, the client would present with a flu-like syndrome with fever, headache, myalgia, chills, anorexia, and frequently diarrhea lasting 3 to 7 days. The lungs will be presenting with a dry cough and marked shortness of breath. Usually a chest x-ray by day 7 will show the patchy areas of interstitial congestion and hypoxia. This can increase rapidly and sometimes require mechanical ventilation. Lymphopenia, thrombocytopenia are often present, as are increased C-reactive protein levels. Elevated liver enzymes were found in several cases and appeared to be resulted from liver damage by the virus. A number of patients continue into a third stage with severe and sometimes fatal respiratory distress. This is talking about the treatment for SARS, so you don't really need to know that. Again, for patho, you need to know how does it break the body, what does it look like. COVID-19, coronavirus. This is caused by SARS-CoV virus. The unique pathophysiological characteristics of the virus include rapid and firm attachment to the lung cells, triggering a cytokine storm, especially in older patients and immunocompromised individuals and patients with serious underlying conditions. I told you guys in class about a friend of mine that was 32 years old that died from coronavirus. He had lupus, and cytokine storm did happen. This is when the immune system overreacts. It's very aggressive. It overreacts in the body, and so it will continue to attack. Okay, and they developed this cytokine storm. He actually coded behind it. He went into cardiac arrest. They were able to bring him back, and then it triggered again, and the second time he did not survive. The following effects can also be manifested in critical cases: acute respiratory distress syndrome, or ARDS, shock encephalopathy, myocardial injury, heart failure, coagulation dysfunction, and acute kidney injury. The virus, this COVID virus, is a single strand positive RNA virus. It belongs to the family Coraviridae. It also includes severe acute respiratory syndrome and Middle East respiratory syndrome viruses. The exact triggering of the cytokine storm caused by this virus is not understood, but the effects are dramatic, causing severe inflammation of the tissue that result in severe pneumonia and lung damage. Cytokine storm symptoms can be mild and similar to the flu, or severe and life-threatening, leading to organ failure and death. This happens when the immune system responds to the infection or the immunotherapy drugs more aggressively than it should. Signs and symptoms of COVID are based on different factors, but general signs and symptoms are fever or chills, coughing, sneezing, difficulty breathing, shortness of breath, fatigue, temporary loss of taste, muscle body aches, headaches, sore throat, nausea, vomiting, congestion. Confusion in the older adult. It should be emphasized that these are general symptoms and it can vary greatly from person to person. Even now, we're seeing some new strains, and some of these are not the same symptoms we've previously seen. There are two main general types of testing for COVID: the antibody serological and diagnostic. The antibody tests for the presence of antibodies produced in the body in response to infection and tells us whether the individual already was infected. In severe cases, treatment may be needed, such as mechanical ventilation. Diagnostically, we can use a test to detect the presence of viral genetic material or identifying proteins, and these use the PCR method. This is treatments for COVID. Again, you don't need to know that. Once thought to be declining and under control, TB is increasing globally. The number of predicted new cases is associated mostly with HIV infections and homelessness. M. tuberculosis is transmitted by oral droplets and released from a person with an active infection, then inhaled into another individual's lungs. It is considered airborne. TB can survive in dried sputum for weeks. They are destroyed by ultraviolet light, heat, alcohol, glutaraldehyde, and formaldehyde. It occurs more frequently in people living in crowded conditions, those immunocompromised, malnutrition, alcoholism, conditions of war, chronic disease, or HIV. The TB is caused by the Mycobacterium tuberculosis. It primarily affects the lungs, but it can invade other organs as well. Mycobacterium is an acid-fast, aerobic, slow-going bacillus that is resistant to drying and resistant to many disinfectants. It can survive in dried sputum for weeks. The cell wall also appears to protect the organism from destruction by the normal body defenses, so that the normal response by neutrophils to the infection and the production of purulent exudate does not occur. There are two stages in TB: the primary infection and the secondary infection or reinfection. The primary infection occurs when the microorganisms enter the lungs, are engulfed by the macrophages, and cause a local inflammatory reaction, usually on the periphery of the upper lobe. The secondary or reinfection TB is the stage of active infection. It occurs years after the primary infection, when the bacilli hidden in the tubercules are reactivated, usually because of a decrease in the host's resistance. As the organism multiplies, tissue destruction occurs, forming a large area of necrosis. Captivation occurs with formation of a large open area in the lung and erosion into the bronchi and the blood vessels. At this stage, active TB can be spread to others. Signs and symptoms of active stage of TB are going to be anorexia, malaise, fatigue, weight loss, afternoon low-grade fevers, night sweats, cough is prolonged and becomes increasingly more severe. The sputum becomes purulent and often contains blood. Hemoptysis is common as the blood vessels are eroded. With captivation, spread of the organism into other parts of the lung can occur, and bacilli become present in the sputum where they can be passed on to others. If cell-mediated immunity is adequate, some bacilli will migrate to the lymph nodes, and a granuloma, or the formation of a tubercle, will occur, and it contains live bacilli. So we'll have a type 4 delayed or cell-mediated response. The lymphocytes and the macrophages will cluster together to form this granuloma at the site of inflammation. The granuloma contains the bacilli, some of which remain alive, forming this tubercle. In the center of the tubercle, caseation necrosis develops, forming a core of cheese-like material consisting of dead macrophages and necrotic tissue. In healthy people, they can resist this invasion, so the lesions remain fairly small and they can be walled off by fibrous tissue, eventually calcifying. The lesions in the lung and the lymph nodes are referred to as Gould complexes. When calcified, the tubercle may be visible on the chest x-ray. By about 6 to 8 weeks, the immune response is complete. This is considered a primary or latent infection. The individual has been exposed and infected but does not have the disease, and they're asymptomatic. The individual cannot transmit the disease. By about week 6 or 8, the immune response is complete, and this is considered again a primary or latent infection. The hypersensitivity reaction first initiated by the M. tuberculosis is the basis for the MAN2 TB test, which detects the exposure to the bacillus. The person has become hypersensitive and will produce a positive skin reaction, this large area of induration. A chest x-ray and a sputum culture will determine whether the active infection is present. In people with low resistance for any reason, the primary infection may not be controlled, but instead progress to active infection. So this slide is just showing you what we just talked about, how you inhale the Mycobacterium tuberculosis. Okay, your body develops this inflammatory response. All right, so you'll develop the primary infection, which means that you really can't give it to anybody else. All right, and you may form a tubercle. You'll get the Gould complex, and unless you develop a reinfection, all right, because you get stressed out or something, that's when you become contagious. On the left, you'll see that also your body can produce this delayed hypersensitivity reaction, and that's what causes that positive PPD. TB almost always exclusively results from inhalation of airborne particles containing M. tuberculosis. They disperse primarily through coughing, singing, or other respiratory maneuvers by people that have active MTB. Miliary or extrapulmonary TB is a rapidly progressive form where we have multiple granulomas. This affects large areas of the lungs. It will rapidly disseminate into circulation and other tissue like the bone or the kidneys. This form of infection is more common in kids and immunocompromised adults. If the patient with extrapulmonary TB has no cough, he or she is not considered to have a contagious disease. In active TB, the active infection can be confirmed with a chest X-ray or acid-fast staining of the sputum specimen. A CT scan is going to be more sensitive than a traditional X-ray in identifying the lesions. The organisms will multiply, form these large areas of necrosis, cause these large open areas in the lungs known as cavitation, and that cavitation promotes spread of the TB into other parts of the lungs. The secondary or reinfection stage is the active infection, and this happens sometimes years after the primary infection when the bacilli hidden in those tuberculosis are reactivated, usually because of decreased host resistance. Occasionally, there's a new invasion. All the organisms multiply, tissue destruction occurs, again, forming these large areas of necrosis. Hemoptysis is common as the blood vessels erode with cavitation, spread of the organism into other parts of the lung are promoted. So this picture is to show you the cavitation if you look at the apex in the right upper lobe. Diagnostically, okay, we'll do the PPD test, the acid-fast sputum, chest X-ray, culture sensitivity of the sputum. Again, you don't need to know what the treatment is. They're not going to ask you about that. They use a number of products here. Histoplasmosis, this is a lung infection caused by inhaling spores from the fungus Histoplasma capsulatum, and it's found in soil, especially where there are bird or bat droppings, and then it's released into the air when the soil is disturbed. It's common, and it's considered an opportunistic infection in people with AIDS. The fungus tends to disseminate or spread easily through the body, and it's found as a parasite in the macrophages. The effects of histoplasmosis are similar to those of TB. First stage is often going to be asymptomatic. Second stage, active infection. Second stage involves granuloma formation, necrosis, and consolidation in the lungs. Signs and symptoms are going to be cough, marked fatigue, fever, and night sweats. Next is anthrax. This is a bacterial infection caused by gram-positive bacilli. These spores can be viable for a long period of time. It can affect your skin, your respiratory, or your digestive tract. Anthrax is a bacterial infection of either the skin, the respiratory tract, or the GI tract. It can happen in people and in cows. It also could be used for biological warfare. Inhalation anthrax causes flu-like symptoms after a period of incubation for 1 to 7 days, and then after about 3 to 5 days, severe acute respiratory distress with mediastinal widening on the X-ray and fever. Shock follows quickly because of the release of the toxins. In the skin or cutaneous form, we'll see a group of blisters and bumps that can itch. There could be swelling around the sore. They may have painless open skin sores with a black center. The sores can occur on the face, neck, arms, or hands. With the inhalation type, we'll see fever, chills, chest discomfort, shortness of breath, confusion, cough, nausea, vomiting, stomach pains, headaches, sweats, tiredness, or body aches. And with the GI form, fevers, chills, swelling of the neck or neck glands, sore throat, nausea, diarrhea, headache, vomiting, flushing, red face, stomach pain, fainting, abdominal swelling. Again, you don't need to know treatments here. You need to know the cause and what does it look like. Obstructive lung disease. These are things like cystic fibrosis, lung cancer, aspiration, obstructive sleep apnea, and asthma. Cystic fibrosis is the first one. This is an inherited genetic disorder with the gene located on chromosome 7. This causes tenacious mucus to be produced from the exocrine glands. The primary effects are seen in the lungs and the pancreas. With the lungs, it obstructs the airflow because it blocks up all those bronchioles and the small bronchi with that thick, sticky mucus, and it can cause permanent damage to the bronchial walls. Infections are common here, caused by Pseudomonas aeruginosa and staph. The first sign is typically that meconium ileus in newborns. So here the baby doesn't pass the stool. And we also will see blockage in the pancreatic ducts, obstruction of the bile ducts, and the salivary glands can also be affected here. In the reproductive tracts, we'll see obstruction of the vas deferens for men, leading to sterility, and obstruction of the cervix in females, leading to infertility. The sweat glands also have a high sodium chloride content here, so there's an imbalance with the sodium and the chloride. All right, so you can see the slide here. We have cystic fibrosis. This is autosomal recessive, meaning you need one bad gene from each parent to get it. It's an exocrine gland dysfunction. We have excessive amounts of thick, sticky mucus that obstruct the ducts of the exocrine glands. So it's going to obstruct the lungs, the digestive tract, and the reproductive tract. So we have obstruction of the airway and frequent infections, fibrosis, cor pulmonale. We have obstruction of the digestive tract, which leads to intestinal obstruction of the newborn. They don't produce the first stool. This is known as meconium ileus. We have obstruction of the pancreatic ducts and the bile ducts. The pancreatic duct produces enzymes for digestion, so that's going to affect the body's ability to break down the fats and the biles for absorption in the ileum. And then fibrosis, diabetes. We have obstruction of the bile ducts in the liver, which can cause biliary cirrhosis. And the combination of obstruction to both of these will lead to malabsorption. We have obstruction of the vas deferens, which would block the sperm, and obstruction of the cervical mucosa, which blocks entry of the sperm. So both of those lead to infertility. The sweat glands produce excessive salt and chloride, and we have an electrolyte imbalance and dehydration. The skin's going to be really salty here. So signs and symptoms are going to be that meconium ileus at birth, which means they didn't pass the first stool, the salty skin, which we can do a sweat test and a diagnosis here. Signs of malabsorption, so that's going to be that fatty stool that's foul smelling with big white chunks in it, known as steatorrhea, abdominal distension, chronic cough, frequent respiratory infections, and failure to meet the developmental milestones. Again, diagnostic and treatments you don't need. Lung cancer, about 90% of these are related to smoking. Bronchiogenic carcinoma is the most common type of malignant lung cancer. This arises from the bronchial epithelium. We have squamous cell carcinoma, which develops from the epithelial lining of the bronchi, and then adenocarcinomas and bronchioalveolar cell carcinomas, which are usually found on the peripheral surfaces of the lung. So this was just a slide from your book. If you look in your book at figure 13 to 16A, you'll see it. It's just a picture of the lung, what it looks like with the bronchiogenic carcinoma. So the problem with the tumors is they can obstruct the airflow into the bronchus. They can cause abnormal breath sounds, shortness of breath. This can lead to inflammation and bleeding around the tumor. They can have cough. They can have hemoptysis or secondary infections. This can also lead to things like pleural effusion, hemothorax, or pneumothorax, and then paraneoplastic syndrome. This is when the tumor itself starts to produce certain hormones. Okay, and it causes things like Cushing's syndrome and things along that line. small lung cell cancer. SIADH. Okay, because it's releasing ADH. So it can release ADH, it can release cortisol, and cause complications because of that. And then unusual systemic effects of cancer will be seen with these. So signs and symptoms are going to be persistent productive cough, detection on the x-ray, hemoptysis, pleural involvement, chest pain, hoarseness, facial or arm edema, headache, dysphagia, and atelectasis. They can also have weight loss, anemia, fatigue, again, the paraneoplastic syndrome from the release of those hormones. And then signs of metastasis are going to be bone pain, cognitive deficits, and motor deficits. Diagnostically, these are the tests, but you don't have to know those really. How to break the body, what's it look like? Same thing, treatment. Aspiration, this is when we swallow food or fluid or vomit into the trachea and the lungs. It's more common in young children or people that lay down when they eat or drink. It can cause obstruction if we aspirate a solid object, and then it can also lead to inflammation, swelling, because the aspirate itself is irritating, and it can predispose us for pneumonia. Potential complications are going to be inflammation, respiratory distress syndrome, pulmonary abscesses, and systemic effects. So as far as inflammation, that can impair the gas infusion. They can develop respiratory distress if the inflammation becomes widespread. If they swallow or aspirate some sort of bacteria, it can cause an abscess to develop. And if the aspirated materials are absorbed into the blood, it can cause systemic effects. Signs and symptoms are going to be coughing and choking with shortness of breath, loss of voice if it's a total obstruction, stridor and hoarseness if the upper airway is obstructed, wheezing, tachycardia, tachypnea, nasal flaring, chest retractions, hypoxia, cardiac and respiratory arrest. So emergency treatments are going to be on here, but again, you don't need to know treatment. And we don't use Heimlich maneuver anymore. We use abdominal thrust. Next up is obstructive sleep apnea. This is from the pharyngeal tissue collapsing during sleep. This causes repeated and momentary cessation of breathing, known as apnea. Men are often more affected than women, and predisposing factors are obesity and aging. Again, you don't need to know the treatment. All right, next up is asthma. We have bronchial obstruction. It occurs in people with hypersensitivity or hyperresponsive airways. It may occur in childhood or an adult onset, and often there's a family history of allergic conditions. There are two types. We have extrinsic asthma and intrinsic asthma. You need to know the difference. Extrinsic is going to be that acute episode triggered by a type 1 hypersensitivity reaction. Usually that onset is going to be during childhood. With intrinsic asthma, this is often during adulthood. You have hyperresponsive tissue in the airway that initiates the attack, and usually it's stimulated by something like a respiratory infection, stress, exposure to cold, inhalation of irritants, exercise, drugs, etc. There are pathological changes that occur in the bronchi and the bronchioles, so we'll have inflammation of the mucosa with edema, bronchoconstriction caused by contraction of that smooth muscle. We'll have increased secretions with thick mucus in those airways, and this causes what we call remodeling of the airway. So it creates this obstructed airway, either partially or totally. Signs and symptoms are going to be marked shortness of breath, cough, tight fillings in the chest, wheezing, rapid labored breathing, expulsion of that thick or sticky mucus, tachycardia, and pulsus paradoxus, where we have a pulse that differs on inspiration versus expiration, and hypoxia. This can also cause respiratory alkalosis because of the hyperventilation, and sometimes respiratory acidosis because air can also be trapped because of the bronchoconstriction. Severe respiratory distress can lead to hypoventilation, which leads to hypoxemia and respiratory acidosis. Eventually, this could lead to respiratory failure, decreases in the responsiveness, and cyanosis. So this picture is showing you that acute episode where we have edema of the mucus that forms that mucus plug. Bronchospasm occurs here. We have the production of excess mucus, and the bronchioles become obstructed because of that, and inflammation. With asthma, acute asthma, we have status asthmaticus. This is a persistent, severe attack of asthma. It doesn't respond to the usual treatment. It's a medical emergency, and it can be fatal because of severe hypoxia and acidosis. Also, if someone's wheezing and they suddenly stop wheezing, you need to take a really close look at what's going on. All right. Next is going to be treatment. Of course, we don't do treatment, but I'll put it up there for you. That's what it looks like. You don't have to worry about this for the test. Okay, these are all treatment. Next up is chronic obstructive pulmonary disease, and this includes emphysema, chronic bronchitis, and bronchiectasis. Chronic obstructive pulmonary disease is a group of chronic respiratory disorders. It causes irreversible and progressive damage to the lungs. This can affect someone's ability to work. It can also lead to the development of cor pulmonale, and respiratory failure can occur here. Cor pulmonale is right-sided heart failure, and it typically happens because of high pressure in the lungs that causes the right ventricle of the heart to enlarge and fail. COPD is a common cause. So these are your three chronic obstructive diseases. I would take a good look at this chart and look at the difference between the three of them. What's the pathophysiology of them? Okay. How does it break the body? What does it look like when it does? So emphysema, this is where we have destruction of those alveolar walls and the septae. This causes large, permanently inflated alveolar air spaces. It's classified by specific location of changes, and contributing factors are genetic deficiencies, genetic tendencies, cigarette smoking, and pathogenic bacteria. Here you can see the normal alveoli, and this is what the alveoli will look like with emphysema. So they become overinflated. We'll lose the septae and the capillaries. The decreased surface area will have loss of elasticity and a decrease in the coil. Also with emphysema, we'll see air trapping because, as you can see, the end of the airway there becomes obstructed and it collapses. It doesn't have that elasticity. It can't recoil there. So the picture on the right shows you the way it's pulled in and collapsed, and that traps the air. With emphysema, we'll see a breakdown of the alveolar wall, which results in loss of the surface area for the gas exchange, loss of those pulmonary capillaries, loss of the elastic fiber, and an alteration in the ventilation perfusion ratio. We'll also see a decrease in support for other structures. This fibrosis can develop, narrowing the airways, weakening the walls, and interfere with passive expiratory flow. This picture's in your book. It's picture 1319. It didn't come up on the slide for some reason. With emphysema, we'll have progressive difficulty with expiration. The air gets trapped. We'll see an increase in the residual volume, overinflation of the lungs, Fixation of the ribs in a respiratory position, which increases the anterior posterior diameter of the thorax, leading to that barreled chest, and the diaphragm will look flat on x-rays. With advanced emphysema and loss of tissue, the adjacent damaged alveoli will form large air spaces. We'll see pneumothoraxes develop, especially when the pleural membrane surrounding the large plebs ruptures. Hypercapnia can become very pronounced. Hypoxia becomes the driving force of respiration. We'll have frequent infections and pulmonary hypertension, and cor pulmonale can develop in the late stages. Signs and symptoms are going to be dyspnea, which occurs first on exertion, hyperventilation with prolonged expiratory phase, development of the barrel chest, anorexia, weight loss, clubbed fingers, and then there's your diagnostic treatment. With chronic bronchitis, we'll have inflammation, obstruction, repeated infections, chronic coughing twice for 3 months or longer in a 2-year period. History of cigarettes, smoking, or living in that urban or industrial area. This leads to inflammation and swelling of the mucosa, hypertrophy and hyperplasia of the mucous glands, fibrosis and thickening of those bronchial walls, low oxygen levels, severe shortness of breath and fatigue, and then it can lead to pulmonary hypertension and cor pulmonale. Other signs and symptoms are going to be a constant productive cough, tachypnea, shortness of breath, frequent thick purulent secretions, cough and rhonchi that are more severe in the morning, hypoxia, cyanosis, and hypercapnia caused by the airway obstruction, polycythemia because the body is in a hypoxic state, so it's going to produce additional red blood cells trying to correct that, weight loss, signs of cor pulmonale, as the vascular damage and pulmonary hypertension progresses. This is treatment, which you don't need. Bronchiectasis, this is usually a secondary condition. It's irreversible abnormal dilation of the medium-sized bronchi. It may be saccular or elongated. It comes from recurrent inflammation and infections. Leads to obstruction of the airway, weakening of the muscle, and elastic fibers in the bronchial walls, or both. The organisms that usually cause this are streptococci, staphylococci, and pneumococci, along with Haemophilus influenza. Signs and symptoms of bronchiectasis are going to be chronic cough with large amounts of foul-smelling sputum, rales and rhonchi in the lungs, foul breath, shortness of breath, hemoptysis, weight loss, anemia, and fatigue. Treatment, you don't need that, but I'll show it to you anyway. Restrictive lung disorders. This is a group of disorders with impaired lung expansion and reduced lung capacity. So here we have the abnormality of the chest wall, which limits or impairs the lung's expansion. We'll see this with things like kyphosis or scoliosis, polio, amyotrophic lateral sclerosis, ALS, Lou Gehrig's disease, botulism, and muscular dystrophy. Second group are diseases that affect the supporting framework of the lung, so like idiopathic pulmonary fibrosis and occupational diseases. We're starting with pneumoconiosis. This is a chronic restrictive disease from long-term exposure to irritating particles. It leads to inflammation and destruction of connective tissue. It affects the functional areas of the lungs. The onset is slow. First, they'll develop shortness of breath. People that you see develop this pneumoconiosis are co-workers, people exposed to asbestos, farmers that are exposed to different funguses. Next are vascular disorders. pulmonary edema and pulmonary embolus. With pulmonary edema, we have fluid that collects in the alveoli and the interstitial area. This can be from several different conditions. It reduces the amount of oxygen available to the blood, and it interferes with lung expansion. This can happen if inflammation is present in the lungs because it increases the permeability of the capillaries. If the protein levels are low, because that decreases the osmotic pressure, allowing the fluid to move or stay in that interstitial area, and also when pulmonary hypertension develops. So again, in this picture, we look at the high hydrostatic pressure that leads to the interstitial edema. The fluid goes into the alveoli and it reduces the amount of oxygen available. The fluid dilutes the surfactant, causing the alveoli to collapse, and it leads to hypoxemia. So what signs will we see with pulmonary edema? We're going to see cough, orthopnea, and rales. If we have an increase in the congestion, we'll also see hemoptysis with that frothy sputum. Breathing can become difficult. Hypoxia can develop here, and cyanosis. And then those are your treatments. All right, next up is pulmonary embolus. This is where a blood clot or a mass obstructs the pulmonary artery or one of its branches. The embolus effects would depend on the size, the type of material. A small pulmonary emboli can be silent unless it involves a large area of the lung. Large emboli can cause sudden death. 90% of the pulmonary emboli come from a DVT in somebody's legs, and they're preventable. Signs and symptoms. Small emboli is going to be transient chest pain, cough, and shortness of breath. With the larger emboli, we'll see chest pain, tachypnea, sudden shortness of breath, hemoptysis and fever, hypoxia, and a sympathetic response with anxiety, restlessness, pallor, and tachycardia. With the massive emboli, we'll have severe crushing chest pain, low blood pressure, rapid weak pulse, and loss of consciousness. How to prevent these emboli are teaching embolic stockings, anticoagulants. There's your treatment. All right, so the embolus forms from the leg vein. A single small embolus can be silent. Multiple small emboli require equivalent. Multiple small emboli are equivalent to a large one. The moderate-sized embolus is likely to cause respiratory distress and pulmonary infarction. Very large embolus will block all pulmonary circulation, leading to shock and cardiac arrest. The large emboli also causes a decrease in the blood returning in the pulmonary vein and a decrease in cardiac output. Expansion disorders, these are things like atelectasis, pleural effusion, pneumothorax, flail chest, infant respiratory distress syndrome, and acute respiratory failure. So with atelectasis, the part of the lung doesn't aerate or it collapses. This causes a decrease in the gas exchange and hypoxia. The alveoli has no air in it. It becomes airless. It collapses, and inflammation can develop or atrophy can develop here. This interferes with blood flow through the lung. It's going to affect both ventilation and perfusion, and also the oxygen's ability to diffuse. Mechanisms that result in atelectasis can be obstructions or reabsorption atelectasis caused by total obstruction of the airway. Compression atelectasis, which is where a mass or a tumor puts pressure on part of the lung. Increased surface tension in the alveoli can prevent expansion of the lungs. Fibrotic tissue in the lungs or the pleura can restrict expansion and cause collapse. And then they can have post-op atelectasis, which can happen after surgery. So if you look at this one here, it's showing you the obstruction in the airflow, and the remaining air goes into the tissues and it's not replaced. Signs and symptoms: if it occurs in a small area, it's usually asymptomatic. If it's in a large area, it can cause shortness of breath, increases in the heart and respiratory rate, and chest pain. Again, there's your treatments, which you don't really have to know here. Next is our pleural effusion. This is the presence of excessive fluid in the pleural cavity. This causes an increased pressure in the pleural cavity, and it can separate the pleural membranes. We can have exudative effusions. These are usually from some sort of inflammatory response in the body, and we can have transudate effusions. There is a watery type that is caused by a hydrothorax, and this can also be caused by an increase in hydrostatic pressure or a decrease in osmotic pressure in the blood vessels. Signs and symptoms of that pleural effusion are going to be dyspnea, chest pain, increased respiratory and heart rate, dullness to percussion, and absence of breath sounds over the affected area, and potential tracheal deviation and hypotension. Okay, there's your treatment. Pneumothorax, this is air in the pleural cavity. We can have a closed pneumothorax where the air enters the pleural cavity from the internal airway. There's no opening in the chest wall here. We can have a simple or spontaneous pneumothorax from some sort of tear on the surface of the lung. We can have secondary pneumothoraxes that are associated with respiratory disease, rupture of the emphysematous bleb on the lung surface, or erosion by some sort of tumor or tubercular cavitation. Here's your types of pneumothorax. Tension is usually going to be an emergency, and then you have opened or closed. Look at them, know what the differences are. What would they look like? All right. You can have an open pneumothorax where the atmospheric air enters the pleural cavity through some opening in the chest wall, like somebody stabbed somebody, one of your clients. This will present a sucking sound in the wound, and they'll have a large opening in the chest wall. You can have a tension pneumothorax. This is typically an emergency. This is the most serious form. It results from an opening through the chest wall and parietal pleura, or from a tear in the lung tissue and visceral pleura. Air enters the pleural cavity on inspiration, but the hole closes on expiration. The trapping air causes an increase in the pleural pressure and atelectasis. Signs and symptoms are atelectasis, shortness of breath, cough, chest pain, breath sounds that are reduced, unequal chest expansion, hypoxia, and interference with the venous return that leads to hypotension. So treatment is get him to a hospital right away. Cover that wound with an occlusive dressing, the one that's making that sucking sound. Usually we put the sterile dressing over it with 3 sides taped down, 1 side open, or an occlusive dressing. Penetrating objects are not to be removed, and if possible, convert it to an open pneumothorax by removing loose tissue or enlarging the opening. Next is flail chest. This is from the fracture of the ribs. The ribs kind of move like an organ, and so when you have this flail chest, they're not able to do that. This allows the ribs to move independently during respiration. During inspiration, the flail or broken section moves inward instead of outward. The inward movement of the ribs prevents the lung from expanding. The large flailed section can compress the adjacent lung tissue and push air out of that section up the bronchus. Air from the damaged lung crosses the other lung with newly whispered air. During expiration, the unstable flailed section will push outward, increasing the intrathoracic pressure. You'll see paradoxical movement of the ribs, which alters the airflow during expiration. Air from the unaffected lung will move across the affected lung, and they'll develop hypoxia because of the limited ability to expand and decrease the inspiratory volume. So here you see the flail chest. You have the injury to the thorax. This causes multiple fractured ribs, and it causes the loss of the rigidity of the chest wall. The large flailed section causes air from the affected lung to flow across to the unaffected lung. So in inspiration, there's a low pressure in the lungs that puts the flail section inward, compressing the lung on the affected side. And then the large flail section causes the air from the unaffected lung to flow into that affected lung. There's a high pressure inside the lungs, and that lung pushes the flail section outward. Infant respiratory distress syndrome. This is usually related to premature birth. We have a lack of surfactant in the alveoli, or they're poorly developed, the alveoli, and they're difficult to inflate. This causes diffuse atelectasis. There's a decrease in pulmonary blood flow, pulmonary vasoconstriction, and severe hypoxia. There's also poor lung perfusion and a lack of surfactant. This will lead to increased alveoli capillary permeability. Fluid and protein will leak into the interstitial area and the alveoli, and the hyaline membrane will formate here. Signs and symptoms are going to be respiratory difficulty. This could be evident at birth. Rapid, shallow respirations, frothy sputum, expiratory grunt, blood pressure falls, cyanosis and peripheral edema develop, severe hypoxemia and decreased responsiveness, and irregular respirations with periods of apnea, decreased breath sounds. So again, this is your diagnostic and your treatment, which you don't really need to know. Adult respiratory distress syndrome is going to come from some injury to the alveolar wall and the capillary membrane. This causes chemical mediators to be released. That increases the permeability of the alveolar capillary membrane, increases the fluid and the protein in the interstitial area, and the alveoli will have damage to the surfactant producing cells and diffuse necrosis and fibrosis if the patient survives. This is caused by a multitude of predisposing conditions, and it's often associated with multiple organ dysfunction or failure. Signs and symptoms of ARDS are going to be dyspnea, restlessness, rapid shallow respirations, increased heart rate, and a combination of respiratory and metabolic acidosis. Again, you don't need to know the treatment, but there it is. Here we have an injury to the alveolar wall. This is ARDS. That increases the capillary permeability due to the cell damage. The fluid and the protein leaks into the alveoli and the interstitial space. This causes pulmonary edema. We'll see a decrease in the surfactant production. This decreases the compliance, leads to labored inspiration. We have respiratory insufficiency. We'll have a decrease in the oxygen exchange, a decrease in the volumes in the lungs, hypoxemia, and atelectasis, and respiratory failure. And as a result, will be confused, decreased responsiveness, severe hypoxemia, progressive metabolic and respiratory acidosis, cardiac arrhythmias, and shock. We'll see all here. Acute respiratory failure. This can result from acute or chronic disorders, emphysema, combination of chronic and acute disorders, acute respiratory disorders, many of the neurotransmitter diseases. Signs can be masked or altered by primary problems. And then, of course, your treatment. And that will conclude respiratory.